Good evening and welcome. I'm Kevin Gibbons. I'm the Executive Director of UBMD and the Senior Associate Dean for Clinical Affairs at the Jacobs School of Medicine and Biomedical Sciences, Western New York's medical school that has trained approximately three-quarters of the physicians in Western New York. And I'd like to invite you, or I'd like to welcome you for joining us this evening. We have approximately 1,000 members of our community who are signed up and here to get an update on COVID-19 from the patient and the community's perspective. We have with us tonight several experts who are going to give us updates in terms of this disease in our community, in our country, and in our world. We're going to talk about some very basics of the virus. We're going to talk about testing. As our governor says, it's testing, testing, testing. We'll be talking about tracking timelines. We'll be talking about the primary care and healthcare's response to COVID-19. We'll be talking about transforming hospital care, and in particular in the ICU. And we'll hear about COVID-19 and pregnancy. And then we'll finish up with what people can do at this time to limit their risks in the face of this disease and to see in the future where we might stand with vaccines and other therapies. So if we can go to the next slide, Megan. So this is sort of a very basics. This is a mini medical school for the first 5 minutes. This is the essentials of biology and understanding what this virus is. You don't have to memorize this slide unless you're planning on applying to medical school and taking the MCATs next week. Well, we can start by talking about coronavirus and what a virus is not. A cell is the smallest unit of life, all right? Viruses are not cells. They're significantly smaller than that. And I include this slide to note that there are so many common features in a cell, whether it's a single cell bacteria or the cell within the human body, of which we have 40 trillion cells and many, many different cell types and tissue types. You don't need to memorize this. It's important to note that there are so many similarities. It's also important to note that there are differences. And it's those differences that allow us to find or design drugs that can kill a bacterial cell without harming or hurting a human cell. We call those drugs antibiotics. And that's why we've been successful, not completely successful, but that's why we've been able to develop treatments for bacterial infections, which for so much of the history of humanity were really the greatest scourge. But now we're dealing with viruses. If we can go to the next slide and then one beyond. Good. So this is a virus on the left side of your screen. It's about as simple as you can get. It's a single strand of DNA or RNA. In the situation with SARS-CoV-2, which is the virus that causes COVID-19 disease, it has only 15 genes versus the thousands that we saw previously in the human cell. The important thing to note is in the bottom right-hand side. This is metabolically inert. It doesn't have any real organelles or mechanisms within itself to replicate. For it to replicate, it has to invade a cell and take over the normal processes of that cell to replicate and continue on. So when we talk about coming up with antiviral drugs, it's much harder because the drugs that stop the virus from replicating invariably can hurt the normal processes of a human cell. That's why when I was a medical student, a resident, there was a single antiviral drug, acyclovir, which was used to treat herpetic encephalitis. It's now used in the treatment of shingles or zoster. And now there are many more antiviral drugs, many of which were developed during the treatment of the AIDS and HIV epidemic. But it's still limited compared to what we can do with antibiotics for bacterial disease. Next slide, please. This is sort of a two stages that give you some sense as to the size of viruses. In the picture on the right, that large circle you see is a staphylococcus or staph bacterium. It's slightly smaller than a red blood cell, which is the smallest human cell we have. And you can see below it various sizes of viruses represented. And these, go from the very large pox viruses to the teeny tiny pico-RNA viruses. And the SARS-CoV-2 virus is about the same size as an influenza virus, or a little bit smaller. Next slide, please. To give you another representation, this, for those of you who don't know, this is an iPhone. I'd like you to think of it as a cell. It's got its own energy. It's got memory. It has a lot of processes inside it that make it work. Next, Megan, please. Here is a representation of what a virus is like. It's about a nail in terms of both size and complexity compared to the iPhone. So keep that in mind when we talk about the virus as an enemy. It's not a thinking, living, breathing machine. It's a virus. It's a piece of genetic material wrapped in a protein coat. Next. Dr. Tomaszewski and Dr. Sellick are both going to talk a little bit about antibody testing and immunity. This is the one pager to explain what that's in part about. Antigens are things that your body identifies as foreign that generate an immune response. When we talk about antigens, they can be proteins on the surface of a virus or an antibody, or a bacterial cell. They can be part of your own body or part of your own cells for people who have autoimmune diseases. There are what we call good antigens, and these are things that are accessible. They're typically proteins. They're on the surface of the cell or the virus, and they're generally stable. We also deal with bad antigens. These often have increased lipid or fat. They can sometimes be internal to the actual bacterial cell or the virus, okay? And they can change. Part of the problem with the flu is that there are two major surface antigens on the flu, and they have several subtypes, and they keep mixing and assorting year by year. So when we talk about H1N1, that's a specific combination of surface antigens for the flu virus. When we talk about antibodies, those are proteins that our body develops that are very specific to a given antigen. They're exact lock and key type mechanisms. The most important of the 5 antibodies that we talk about is IgG. That's the one that's circled in the middle in UB blue. It's a Y-shaped structure. The tips of the Y are specific to linking to an antigen. The base of the Y is something that links to certain cells within our immune system. This constitutes about 80% of the antibodies in our body, and it is the most important one, and it's the one that we'll talk a little bit about tonight. Next slide, please. When we say this is a novel virus, we don't mean that it has, the ability to read War and Peace of the Great Gatsby. What it means is that it's brand new in terms of its antigenicity, and that's a scary problem. It means none of us have intrinsic immunity to it from either previous exposure or from a vaccine. So in the United States of America, with 330 million people, it means that eventually almost everyone gets it. Actually, about 20% of people don't get it. It takes about 80% to develop true herd immunity, where the virus peters out because it can't find new people to infect. But if you take 330 million people, 80% of that is in the 270 range. If you have a fatality rate of 1%, that means 2.7 million people die in this country from this disease. It's highly contagious. When we say contagious, it means how easily it spreads. You've heard about R factors. It spreads via aerosol droplets, and it can live on a surface for an undetermined period of time. The strange thing about this virus is that people can be very contagious before they have any symptoms for a period of 4 to 6 days. And there's a large number of people who are infected but are completely asymptomatic for 12 to 14 days. And in studies of young individuals, half to almost 2/3 of people can be completely asymptomatic but contagious. And it's a virulent virus. It causes a primary infection. It enters through the mucous membranes. It affects the upper respiratory tract and the lower respiratory tract in a significant number of people. It can generate a secondary inflammatory phase where your body then attacks the infected tissue and probably causes more harm than good. It can cause inflammation of part of our heart muscle, and it can cause increased clotting. And Dr. Nadler will probably talk about that later on. Next, please. And it's important to compare this to things we know. So when we talk about the common cold, it's highly contagious, but it's not virulent. People may think they're going to die from a bad cold, but they generally don't. When you compare it to the flu is highly contagious, but people who have the flu know they have the flu, and people around them know they have the flu. They're generally quite sick. And the flu does indeed have moderate virulence, and a good number of people, from 30 to 70,000, die every year in America from the flu. Next. So the symptoms of COVID-19 from the CDC: cough and shortness of breath, and typically two of the following: fever, chills, muscle pain, headache, sore throat, and a particularly unusual symptom, that is the loss of taste or smell. We'll hear a little bit more about this as we talk about this. Next. So finally, the mortality rate. Dr. Sellick's going to talk about this, and I'm going to talk about this a little bit in the wrap-up. The mortality rate is very much age-specific. Next slide. And comorbidity specific. 90% of the people who die from this disease have comorbidities, but they're not necessarily severe comorbidities. It's not that they're in severe congestive heart failure. People with mild, successfully treated hypertension, or people who are mildly obese, have a much higher fatality rate than people who don't. So that's one of the scary things about this drug, or about this virus that we're dealing with now. So with that, I think we'll move on into the next. And this is going to be Dr. Tomaszewski, who is the head of UBMD Pathology, the chair of the Department of Pathology, and the head of the Kaleida Health Laboratories. Thank you, John.
Thank you, Kevin, and pleasure to be here, everyone. So I'd like to tell you a little bit about a journey that we've been on for about 2 months of regional testing for COVID-19 patients, and some of the challenges that we've had along the way. Next slide. So we established that this disease that has some very significant mortality attached to it is secondary to a virus. We actually didn't know that until sometime in December of 2019. And the sequence of this virus, the sort of information in the RNA of the virus that tells the virus how to assemble itself, was not sequenced until the middle of January of 2020. So we've only known about this virus for a little over 3 months, for real. And we've learned a ton about it, both clinically and in terms of its biology, but we only know a small fraction of the information we need to know. We know that this is a acute respiratory tract infection. So it is caused COVID-19, coronavirus disease 2019, COVID-19, is caused by this coronavirus called SARS-CoV-2. So there was a SARS epidemic in 2003. It was also a coronavirus, severe adult respiratory distress syndrome. And then there was another outbreak of a coronavirus disease called MERS in 2007. And here we are in 2019 and 20 with yet another coronavirus, which is very serious. Now, this virus replicates in the upper respiratory tract predominantly. There are other sites where you can find this virus. And in fact, this virus probably causes inflammatory responses, not only in the upper respiratory tract and in the lungs, but in a variety of other places in the body. So as a laboratory medicine physician, we in the laboratory seek to find the virus. And if you're going to go find it, go look where it might be, which is in the upper respiratory tract. So to get a sample of upper respiratory tract, you have to do a couple things. Next slide. And the most acceptable, and I'm not quite sure why we're kind of losing a little bit of this word, nasopharyngeal, it didn't come quite through, but this is a nasopharyngeal swab, which is inserted through the nose to the back of the throat. And this swab then will, that's good, thank you. This swab then will pick up some of the mucosa back there, and that's where the virus will be in those cells. Now, to test it, we need to get it to the laboratory alive and intact. So we're going to take that swab that we just took out of the nasopharynx, and we're going to put it into that tube off to the right. And that tube has some transport media in it that we're then going to send off to the laboratory. And we don't have like a ton of time to do that. These tubes basically have to get to the lab in a few hours. Next slide. There are other places where you can actually get into the mucosa that has the virus. So you could go through the nose, but you could also go through the mouth to the oropharynx. And this is supposed to be an oropharyngeal swab. And it goes to the back of the throat. Both of these collection techniques, however, cause people to sort of cough and choke. And if they are infected, they will spew an aerosol of the virus around. Hence the need for collection sites to be in places where they're not going to infect everyone and everything around it. So all the images of people suited up with PPE and sort of queuing up in their car to get these kind of test collections are all because of this procedure, which causes you to choke or cough as it occurs. Next slide. So when we get these samples, we have to, in the laboratory, disperse the samples in a media. And our target is the virus, and the virus has different pieces in it. But the thing that we're most interested in to tell whether somebody has an infection is the nucleic acid footprint of the virus. And so this coronavirus is a RNA virus. And so we want to extract the RNA from the virus. And here's a similar cartoon that Dr. Gibbons showed. And this is the RNA attached to a nuclear protein, which we then will extract from the virus. Once we have that extracted, we want to make millions of copies of that. We want to amplify that virus up. And this RNA amplification is done through a technique called a reverse transcriptase polymerase chain reaction. RT-PCR is the simple term. So that RNA that you see there in the where the arrow is undergoes something called reverse transcription in a test tube. We make DNA out of the RNA by doing this reverse transcription. We have a polymerase that will do that. And then that DNA is hybridized with probes using a DNA polymerase. So you can see the little Pac-Man there with a primer, and that Pac-Man's going to go down and put nucleotides onto that template. And some of those nucleotides will include a probe, which will tell us whether a gene from this particular coronavirus is present. The probes have these little light gizmos on the end. So they have a molecule that will fluoresce if it is exposed to light, incident light, and they have a quencher. And the trick here is that when the quencher and the probe are the fluorophore are close together, there's no light comes out, and when they're separated out because they hybridized onto the DNA, you get a signal. And so what we're trying to do is get a bunch of amplified nucleic acid and probe it with these probes that will give us a light signal that tells us whether it's there or not. So in the bottom panel, you see a positive curve and a negative curve. The negative curve you can barely see. It's like a flat line. And the positive curve is a typical curve that we will see when we do this amplification procedure. This is a procedure where we have to raise the temperature and lower the temperature 30, 40 times. And if we get a product, then we will know that that RNA and that probe were there in that sample that we took. Kind of complicated technology, but it is the most sensitive way of finding a pathogen today. Next slide. So nucleic acid testing, you might have gathered, has two parts to it. It's got this extraction of nucleic acid and then an amplification. And when we started this journey about, I guess it's about 8 weeks ago now, we didn't have any assays in Buffalo for this. In fact, nobody did. I'll give you a timeline in a few minutes, but we had to figure out what we were going to do. We had to figure it out based upon instrumentation. We had to figure it out based upon reagents. We had to figure it out based upon personnel. And we actually didn't have any resources in Buffalo at the beginning of this epidemic. Approximately 2 weeks into the middle of March, we had an opportunity to leverage an instrument that was really a research instrument in the laboratories, Kaleida Health Laboratories. We had been hosting this Abbott real-time PCR instrument called an M2000. To do studies with Dr. Andy Tudal, and he's a hepatitis researcher. And we had it in our laboratories to do studies that would be for test development, so-called good lab practice operations. And so we were hosting it. And this arrow here on top is part of the machine. It's sort of a robotic machine that does all that nucleic acid extraction. And we actually, most importantly, we had two outstanding operators. This is Karen. And Karen was one of the two operators that we had trained and who understood this machinery. And we were able to actually leverage this into our first testing opportunity in Buffalo in Kaleida Health Laboratories. And we've been testing ever since on this instrument. It's been a workhorse for us. We also knew that we needed more than one platform. And so in the University of Buffalo's biobank, we had a different kind of nucleic acid extraction instrument, and that's this second arrow below it. It's called a Perkin-Elmer Chemagic 360 nucleic acid extractor. That is a different type of doing the same thing that you see in the upper panel. And we put that together with some thermocyclers that we have, and we created our own pipeline. So the instrumentation that Kaleida Laboratories has actually used along the way here has been, to date, these university type of instruments. We're probably going to get to a third platform in a few days, and that will be on Kaleida instrumentation. Next slide. So, next slide, please. So what you also need is transport media here to move that swab into the laboratory, and we didn't have enough of that either. And so we went down the pathway of creating our own, and it was a great gift by Dr. Campaneri and his folks to help us with the creation of media. And this is a pipeline that goes on. So you see off in the right-hand panel, some of the staff here at Collider Labs putting together literally thousands and thousands and thousands of these kits that have been used to test people. Next slide. So what happened here? Well, the nucleic acid testing started in Buffalo on the 13th, I believe, of March. There was a test that started at the Erie County Public Health Laboratory. This was a CDC test. We got about a day or two later materials to be trialed on our Abbott machine, and we did that validation. And within a few days, we had testing started, and we've continued to test since 3/21. And we've done, as of this morning, I counted 10,401 tests that were either done or in process. So we've done a little bit less than 50% of all the testing in Western New York. Just for background, about 19% of the people are positive. Next slide. So you could test for the virus, or you can test for the immune response to the virus. Dr. Gibbons talked about this. And antibody testing, we were able to bring online here on March 21st. The antibody that we're using is an antibody test to IgG. This is, if there's going to be any place that gives you immunity, this will be the molecule. We don't know that this test indicates in any way, shape, or form immunity, but it does tell you that you've been exposed and that you've actually had a response to it. So to date, we've tested 6,751 tests. There's a difference between the positive rate for healthcare workers who are in hospitals that are safe places, actually, because they're highly scrutinized for cleanliness and for PPE and things like that, versus the community, which is at about 7.5%. I'll just finish up by saying that the usual life cycle of this condition is you get sick, you shed a lot of virus, so you have a lot of viral RNA coming out of your airways, and you start to clear that after a time, and then antibodies start up. And the first antibody that comes up is an IgM. That probably doesn't confer too much protection, but a week or so after that, you start to get IgG. So I'm going to stop right there, Dr. Gibbons, and I will pass it on. Thank you.
Thank you, John. As our governor said, it's testing, testing, testing. That's been the story of the last 6 to 8 weeks, and I think it'll be the story for the next 6 months or more. I'd like to have Dr. John Sellick from the Division of Infectious Diseases from the Department of Internal Medicine talk about tracking timelines, COVID-19 cases, testing, and vaccines. John, thank you.
Yeah. Yes. Thank you, Kevin, for putting this together, and thank you all for joining tonight. Nothing like being on with a few hundred of my closest friends to talk about a pandemic virus. Next one, please. I'm just going to show a couple of these graphs. I think you've seen plenty of these in the paper and on TV, various websites. Just looking at the overall course of this pandemic in New York and in Erie County. Here you see the New York slide, the New York State overall slide. And you see that early on, we're seeing a very rapid ramp up in the number of cases, and you see that the number of positives in relationship to the number of tests being done also was fairly high. Then, going through that, horrendous period of time, it's certainly not over yet, but the worst part in the New York City area, we saw a marked increase in the number of cases. But now recently, in the last couple weeks, you see that we've had a somewhat sustained decline in the number of cases, both total and in relationship to the number of tests being done. Next slide, please. Now, Erie County, you're going to see looks a little bit different. And if you look at that, the left towards the left-hand side of the curve, you see that we did not have a real rapid increase in the number of cases identified, because you probably recall that we had a very difficult time getting testing done. Every time we wanted to get a test done, we had to call up the health department and somewhere between beg and tell stories just to get the test sent out because there were so few. But now that we have much better testing capability, as Dr. Tomaszewski showed you, you can see that we've been able to get a lot more testing done, and we've gone through ups and downs with the numbers positive, but again, of late, we're seeing somewhat of a decrease in the rate of positivity, which is good. Next slide, please. Now, here is one of many graphs like this that you can see, and that's hospitalizations. And the good news is that they went up fairly briskly, but now have leveled out, and actually in the newer data, not completely reflected on these slides, the numbers of hospitalizations have actually been declining fairly regularly. The other thing that's very impressive is if you look at the gold line, that is the number of patients in the intensive care units. And I think that many of my colleagues who are on the podium here tonight, the virtual podium, can't really recall a time where we had such a high percentage of people with a particular disease winding up in the ICU. But this too is declining. And I think the important thing with this, as you've seen, has been discussed multiple times in the last few days, it is safe to come to the hospital. We know that there are a lot of people who are avoiding coming to the hospital because they're fearful of getting COVID-19 in the hospital. And we unfortunately have people who are neglecting important care for their medical conditions. So in all the hospitals in Western New York, the numbers of patients are level or declining. These patients are all on specialized units. They're not out wandering around the hallways. So please don't put off coming to the hospital because you're fearful of getting this. If you have medical problems that need attention, please come in. Next one, please. Here are, Dr. Gibbons showed you a little bit of this, and I picked the left-hand slide off of the State Health Department website, and you can see that the mortality rate is pretty much closely related to age. And this is not terribly different than many other diseases, but it's really quite dramatic with this. And on the right-hand side, there's also been discussion of this lately in many forms of media. You can see that Hispanic and African American populations are disproportionately bearing the burden of death due to COVID-19. You can see more mortalities in those groups than they are percentage-wise than they are represented in the population. The reasons are not 100% clear. Probably has a fair amount to do with comorbidities and access to medical care. Next slide, please. Dr. Gibbons also made mention of this. If you look at this graph is a little bit older, but I like it because it's bright red color. It's my favorite color, and it shows what it needs to show. But you see that there are a lot of comorbidities. But again, as Dr. Gibbons mentioned, hypertension. We know that hypertension is a risk factor for a lot of things, but we don't normally expect that hypertension alone is going to be responsible for a worse response to an infection like this. Now, one of the problems that we have is with this pandemic moving along so rapidly, we've not been able to generate the kind of data that we need. So I suspect that there are a lot of people who have more than one of these red bars as their underlying diseases, but clearly the vast majority of people who die have underlying diseases. Not all, but a very high percentage. Next, please. So antibody testing, Dr. Tomaszewski alluded to this. The presence of antibodies indicates prior infection, not current infection for the most part. There may be some specific cases where we might be able to use it that way. But basically, when we do antibody testing, we are looking for the footprints of someone having been infected. We don't know for sure if the antibodies that we are measuring, are actually protective. And even if they are protective, for how long they might be protective. And then this is true with many pathogens. Our immune systems respond to a lot of things, but not all of them are responsible for preventing us from getting reinfected. Now, the original State Health Department survey that was done, this is the one where people were lined up outside the grocery stores and other department stores and things. Statewide is about 12.3%, something along those lines overall. It was much higher in the New York City area, in the 20% range, and in Erie County, we had about 6%. And as you saw from the fairly large sample done in the Kaleida labs, about 7.5% of our local population. So, I think we're fairly comfortable saying that our background infection rate is somewhere between 6 and 8%. Now, on the one hand, that's great. That means that not a huge number of people have been infected. The other side of that is everybody was, secretly hoping that it was going to be 50 or 60%, which would indicate that we were coming to the end of this, that we would have enough people immune to give us herd immunity, but we're certainly not at that point. Next slide, please. Now, vaccines, everybody asked me about vaccines, and obviously, you watch TV, you see everyone is interested in vaccines. Depending on which accounting you look at, there are somewhere between 75 and 100 different vaccine candidates in various stages of development worldwide, including some in the U.S. I think the key thing here is when we look historically, the typical vaccine development, those of us who grew up in the era where there were no vaccines for mumps, measles, rubella, et cetera, most of those vaccines took a long time. Mumps took about 4 years. Most of the others were at least 10 years because of what you have to do to grow up the antigen that you want to use and get it into a safe format that you can then use to inoculate individuals in the community without causing any harm, and hopefully develop a good, long-lasting immunity. As you probably have some sense, the goal now is to do multiple stages at the same time to try to compress that cycle from 4 to 10 years to maybe get it down to a couple years, and we're just going to have to wait and see how that works out. There are a lot of different types of vaccines being worked on. There's one Chinese company that is doing it the old-fashioned way, growing up the virus, inactivating it, and turning it into a vaccine. Most of the other companies are looking at more molecular-based types of processes, either using mRNA, messenger RNA. Dr. T showed you how that works out in the cycle, but using that delivered in various things like lipid bodies, so that your own cell will develop antigens that your immune system will then see. There are other ways of using different viruses with the SARS-CoV-2 genome put into it to deliver the material to generate an immune response. We don't know which one of these is going to work. Many of these have not been used to great degree. The Ebola virus is what's called a vectored viral vaccine. So they put the Ebola genes of interest into another virus that then replicates and results in immunity. The important thing is that we have to make sure that the antibody that's produced is protective. And again, not just one that's there because your immune system recognized the virus, but that it actually neutralizes the virus so that it cannot move on from cell to cell. And we have to make sure that it's safe, especially if we're going to be giving this to the elderly who are bearing the large burden of disease. We have to make sure that it's safe before we start giving it. So there's a lot of moving pieces as it were going into this, but we're hopeful that some of these very thoughtful techniques will give us a vaccine that does wind up being protective in the way that we hope. Next one. That's it. Thank you.
All right. Thank you, John. As we move a bit more from the science and the epidemiology behind this, we'll be talking about critical care and obstetrical care. But first, we have to remember that at least 80% of the people who have this infection are treated in the outpatient setting, and most medical care is in the outpatient setting. And to give us an update on that is Dr. Dan Morelli, who's the chair of family medicine for UB and head of UBMD Family Medicine, our primary care practice. Dr. Morelli.
UBMD colleagues, welcome to tonight's program. Well, a few weeks ago, the practice of medicine really came to a standstill in lots of ways. Some things changed immediately. For example, some of the less urgent surgeries. But what didn't change was the fact that we all continue to need medical care to maintain our best health. So my talk tonight is going to be focused a little bit on how UBMD has transitioned in this process to continue to meet the healthcare needs of our patients. Next slide, please. Starting with this cartoon by Barry Blitt. He's a Pulitzer Prize winning cartoonist from the New Yorker. And it's a pretty creative way to deal with the virus, but it probably isn't very practical. So as we try to deal with our patients, you're going to need to have something beyond a very handy shower curtain here. Next, please, Megan. So what we've really adapted to very, very rapidly, in fact, is some telemedicine type techniques, as well as some changes in how we manage our care with in-person office type visits. Well, we've done a variety of different things that include what I'd call automotive medicine, the use of personal protective equipment for our staff and our patients, and then modifying various procedures. And I'll go into this in more detail in a minute. Next. So we really have to stay connected. We've worked hard to develop a type of a scaled up response. There's always the telephone. It's been a familiar, easy, long-term way for doctors and patients to connect. But nowadays we've found that there's additional technology that gives us a little bit of a broader ability to care for patients. And it does involve some knowledge on the part of our staff to help to teach patients how to use it. It also involves some patient technology and equipment. So a smartphone, an iPad, a computer. And there are definite advantages to this video world. We can take a more careful look at a patient. We can see how they're doing with their breathing. We can check out growths and rashes. We can look at range of movement of joints. So there's quite a bit of medicine that can be practiced by telemedicine nowadays. Insurance companies have loosened a number of restrictions and made this a lot easier for us to do this across the board. A good history is still the foundation of what we can do. So there's nothing about a video that doesn't help us get a better history. Next. So if you're going to be having one of these virtual visits with your doctors, I have a couple of hints for you. I'm a list guy, as anybody who knows me knows. So I would start by making a list. Be sure all your concerns are on it. If you have a special platform that you're going to use, like your iPad, be sure your connectivity is working. Collect a little information for your doctor or your nurse practitioner or your physician assistant, whoever your healthcare provider is. Measure your weight. Check your blood pressure. Many patients nowadays have home blood pressure monitors. Check your pulse rate. Sometimes you can, if you have a respiratory condition, measure a peak flow with a meter. You can do a pulse ox in some cases. I know that they've been pretty popular on Amazon these days, going for much more than they used to go for. And if you're diabetic or have another condition, you can be sharing your finger stick readings with your doctors. It's very important to have an accurate medication list and dose and frequency. So be sure your bottles are nearby if your list isn't current. And helpful to have a quiet location in your house if that is at all feasible. Sometimes the rest of the family is always in the background, but we can deal with that. Next, Megan. Oh, I think you skipped a slide. Okay, next slide, please. So if you're going to be doing a video chat with your doc, or your nurse practitioner, your physician assistants, a couple of hints, simple hints. Have most of the light coming in front of you. Yeah, otherwise you'll be backlit and it'll be hard to read facial expressions. Most of the offices at UBMD are going to be giving you special information about how you're going to connect, what kind of an application you will use, what type of a sign-in, what type of a login program you're going to have. Plan to log in a few minutes before your visit. You will be placed usually in a so-called virtual waiting room. And when the doctor or the healthcare provider is ready, they will open your visit and you will begin to see someone on your screen and you can start your visit. It's sometimes helpful to be close to your home router. This is highly internet connectivity dependent, and depending on the bandwidth available. Being close to your source for your internet as it comes into your home can sometimes be better. Even with all those precautions, there can often be troubles with fuzzy images, voice delays, and sometimes a downright just a plain old drop call. If that's the case, usually re-entering your login and entering the application again will fix that. Your person on the other side is likely to be trying to do the same thing. Next. This is a quick shot of the kind of note that we would usually be using on one of these telehealth visits, and I wanted to just give you a sense of all the different information that we will be collecting. This is a visit just like an office visit. So we are making an official card and entry into your medical record. We're recording how we spoke with you or visited with you, how much time it may have taken, what problems we took care of, what changes and medications we made, what advice we gave. We can do a host of things nowadays electronically. We can send a requisition to the imaging or radiology offices. We can send laboratory testing to various laboratories. Doesn't require a paper slip on your side, and it doesn't require an office visit. So we can do a number of things that can settle out problems and continue to care for your chronic problems without necessarily having to come into the office. Next. So office visits are a new thing, a new experience. We have very few of them in person these days. I expect that will be changing as we learn more about the penetration of the virus in this community and as the safety of office visits is a little more evident. But our offices have enhanced cleaning. We expect that you'll have a face mask. If you don't, we'll provide one, but the governor expects everybody to be outside with a face mask or cover. Our staff will be likewise protected. You can expect some screening at the entry to the office. We're going to do our best to minimize time in the waiting room. We're going to be offering usually separate times and visit times for patients who are coming in for a more well visit and low risk low COVID risk situations such as immunizations or well child checks. Often our patients can check into the office from their smartphone and car, meaning you don't have to go to the desk. We can escort patients from the front door to a waiting room directly without any need to have other people around. Our staff is being screened daily to be sure that they're not feverish or having any symptoms or signs of any infection. In some cases, we are even able to do your exam in the car. Some of our offices may have more private locations, and we can pop the door and we can talk through the window, and a simple exam, if it's a minor thing, can often be done without even needing to come into the office. And of course, everywhere we look, we are all being extra special careful with lots of hand hygiene and personal protective equipment for our staff. Next slide. So this has been a tough few weeks with the virus. We've been wrestling with it now and trying to learn about it, and it's been teaching us a lot about ourselves and our society. We have a lot more to learn. It's been a time of significant pain and loss, but with also some rays of hope. And this photograph of Winston Churchill sort of, to me, encapsulated a moment when he was leading his country through a very difficult time. There had been months of bombing of London and other cities and lots of pain and loss of life. And the air war of Britain finally ended, and the population was incredibly happy about that. But he wanted to be sure that they knew that they were still in for quite a battle here. So his quote for this, and I'll end with this, is, "Now is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning."
Thank you, Dr. Morelli, for that great update in terms of what we're doing in the world of primary care, which is such an essential part of medicine. When it comes to COVID-19, patients are generally treated as outpatients, but a significant subset, between 15 and 20%, are admitted to the hospital. And depending on the series, a third to half of them are admitted to the ICU. Dr. Jamie Nadler is one of our critical care physicians with UBMD Internal Medicine. He's a chief quality officer at the Buffalo General Medical Center, and he's going to talk about transforming hospital care to meet the challenges of COVID-19.
Thank you, Dr. Gibbons, for putting this on and inviting me to speak today. So how are things different in the last few months as we deal with COVID-19? I would say the most obvious difference is the sheer number of patients that we're caring for with severe respiratory disease, and more specifically, the number of patients who need support on a mechanical ventilator. This is higher than we've ever seen, and we've probably seen as many patients with this condition the last few weeks that we would typically see over a year. This disease, the course it takes, the potential treatments we have to offer, the nuanced differences in management from other viral illnesses, and constantly changing and evolving. And there's certainly things we're doing different. We're learning, we're adapting, we're going along with it. But for today, I'd like to focus on a few important topics that I believe are important for the public to know and are probably interesting. The first, and what has been particularly difficult to deal with, is managing the barriers that now exist between patients and families. One of the most painful decisions I think that hospitals had to make was restricting visitation with COVID. There is no question that visits from family and friends help people recover quicker, and it's something that we typically encourage. But it became clear that for the protection of our patients, staff, visitors, and the community as a whole, we had to take this step. And it has understandably led to a lot of concern and anxiety as families cannot visit loved ones, they cannot get face-to-face updates from the nurses and the doctors. And for patients, the feeling of isolation, fear of the unknown, they're in private rooms, typically with the doors closed, and they're being treated by staff who are in full PPE, which completely depersonalizes. So we try to come up with strategies to add some degree of normalcy and try to keep up the lines of communication. Some of you may have seen that a lot of staff members are putting a picture of their face with their first name in large print on their isolation gowns, in an attempt to add back some element of humanity to the interaction. We have dedicated staff whose only role now is to update families over the phone and field phone calls as they come in. We've had some community members donate iPads, which we now use to have patients speak with their families, and we also have some family doctor meetings through the iPad when patients can't speak for themselves in the ICU. It has been difficult, and the burden admittedly has fallen largely on worried families and their patients, but we continue to work on solutions to try to make this easier. As mentioned earlier, the volume of patients arriving to the hospital with hypoxemic respiratory failure, or those needing high amounts of oxygen, has been exceedingly large. The number needing to go on the mechanical ventilator, as Dr. Gibbons suggested, is near half of those at times. COVID-19 has presented some challenges and changes to our standard management, as it has not behaved as typically. Most patients who are sick with a condition called ARDS, or adult respiratory distress syndrome, typically have very stiff lungs that are hard to inflate, require a lot of work on the ventilator. Their lungs are commonly filled with fluids, and it makes it harder for us to oxygenate. One tactic that we've used for decades, these patients, is to prone them, which literally means flipping them onto their bellies, putting them face down for up to 16 hours a day. We know that this will help redistribute the fluid, will redistribute blood flow more evenly throughout the lungs, and significantly improves their oxygen levels. It's not a cure for the disease, but affords the lungs a chance to recover, keeps the patient's oxygen level up. We have historically reserved this for our very ill patients on the ventilator. As we learn more about the mechanics of the lung and COVID-19 specifically, we realize that this may work for patients who are otherwise awake and really only requiring oxygen through the use of nasal prong. So by having patients even on the medical floor outside of the ICU lay on their stomach to sleep, and at other times throughout the day, we've seen their oxygen levels rebound significantly. And we have avoided, we think, putting some patients on the ventilator using this technique, which for us is a huge win, as most patients who progress to the point of needing mechanical ventilation seem to take a really long time to come off, and normally leads to a lot more complications. You may have seen reports from Italy and New York City about extremely high mortality rates for patients who are put on the ventilators, anywhere from 60 to 80%. But you have to keep in mind that this data is incomplete and it's a bit misleading for various reasons. It should be interpreted with caution. I can tell you at Buffalo General, where I practice, we've had a lot of success at liberating patients from the ventilator despite prolonged illness. Our first patient, who was a gentleman in his 70s, was on the ventilator for more than 2 weeks. He is now extubated, off the ventilator, and at home with his family. Similarly, early on, we had a gentleman in his 20s who came in, was on the ventilator for more than 3 weeks, had a pretty rocky course. He is now at home with his son. And to date, near half our patients have been successfully removed from the ventilator and either graduated out of the ICU or at home or in short-term rehab. Something that has been puzzling doctors lately is this apparent increase in clotting events in patients with COVID-19. It's unclear why this is occurring. There are theories that suggest possible damage to the lining of the blood vessels or hypercoagulable states triggered by infection and inflammation. This is manifest for us locally here as unexpected clots, particularly in the lungs and legs, but may also explain the higher than expected rates of strokes that are being reported in younger patients in New York. The jury is still out on how to tackle this problem. Ideally, we would love to avoid clotting complications, but that means putting patients on full doses of potent blood thinners, and that doesn't come without bleeding risks. The strategy we're employing here, and I know my colleagues are at other hospitals around the city, is to ensure that everybody is at the very least on a low-dose blood thinner, which is already standard practice for most people in the hospital. But what we're doing differently is actively monitoring the levels of that blood thinner in their blood as their body changes, as their illness changes, to make sure that the dose they have is adequate. We are routinely checking for certain blood tests and markers that might, in the right clinical scenario, suggest that patients are at risk for clotting, and choose to start those patients on the full dose blood thinners preemptively. As more data comes in and more studies are done on this, our various strategies are we are going to adopt our approach, try to follow the most reasonable plan. The impact of this disease really has encouraged doctors and researchers, hospitals, governments, other organizations to work collectively. We've been coordinating global trials to develop and study treatments at a speed I don't think anyone has seen before. At UB alone, we are now participating in several approved protocols, something that normally takes months at best to get up and going, but we've accomplished them in days to weeks in cooperation with our colleagues across the world. I'd like to touch on 3 new, what we call investigational treatments. These are not approved for the treatment of COVID, but we are providing them for patients here, and most of them you've probably heard about. The first, which has really garnered a lot of media attention, is the use of something called convalescent plasma. So the theory behind this goes as follows, and you've been luckily primed by my colleagues about what I'm about to say. So if someone is infected with COVID-19, the body's natural response is to produce antibodies to help fight and clear the infection. Some antibodies are short-lived, those IgM antibodies that disappear after the infection is gone, but others will stay around, IgG. These hopefully will provide some protection for what we call immunity against future COVID exposure. So we have been asking people who have recovered from the infection and were swab positive, we know they have the disease, to come and donate the part of their blood that contains the long-term, potentially protective antibodies, which we call plasma. We then transfuse the plasma, similar to a blood transfusion, into patients who have recently fallen ill with COVID-19. The hope is that the donor antibodies will give the patient's immune system a running start while it ramps up its own production of antibodies. The goal to try to prevent patients from sliding into more serious illness, and also hope shorten recovery time to recover. This is not a new treatment. It was first described in the late 1800s to fight diphtheria, and over the next 120 years has been tried with various degrees of success against most notably the Spanish flu of 1918, and more recently against SARS in 2003 and even Ebola. So hospitals around the country are using this treatment. We're collecting data to determine how effective it is so we know if there is a second wave of this disease and effective therapy. A promising new treatment that has just received emergency use approval by the FDA is remdesivir. It's been in the news a lot lately. This medication was originally developed to help fight Ebola, but has shown some activity against several other viruses, including SARS-CoV-2, the virus responsible for COVID-19. It works to directly fight the virus by interrupting its ability to replicate and spread throughout the body. Work to study this drug has really occurred at breakneck speed after it showed a lot of promise in the lab. The first small studies conducted in China were completed. There's now more robust studies that are just finishing up in Europe and here in the United States. And based on what we know from these studies, this drug does appear to shorten the time it takes for patients to recover from COVID infection, and particularly seriously ill patients where it was studied. This seems to have a similar effect as Tamiflu in the treatment of influenza. And as promising as that sounds, unfortunately, at this point, this drug is only available through an IV infusion and does have potential side effects that are best monitored in the hospital. So it is not ready for prime time use in general public outside of a hospital setting, but we'll see where the data. We do believe, as mentioned in previous slides, that patients who deteriorate to the point of needing ICU level of care are likely suffering from a severe inflammatory response to the lungs. It's caused by our own immune system's exaggerated response to the virus. As the immune system tries to kill the virus, it's inadvertently damaging our own body. Around the world for the last couple of months, doctors and researchers have been looking for treatments that might dampen down that inflammatory response to help the body recover. Darilumab is one of the drugs already available on the market and used to help fight infection and chronic conditions such as rheumatoid arthritis. There were some preliminary reports of it being used with some success in treating the inflammatory phase of COVID-19. We here have partnered in a citywide group with Roswell Park, Kaleida, and ECMC to start enrolling patients in a national study designed to see if this medication will help our patients, sickest patients in the ICU. And as most studies go, we've enrolled quite a few patients, a placebo-controlled trial, but still too early to know if this has been working for our patients, but we hope to have some preliminary data results. So these are really the biggest developments and changes to treatment for COVID-19 in our ICUs. I think it's important to remember that none of these medications or treatments offer a magic quick cure for the disease where patients quickly turn around and walk out of the ICU. But rather, they give us tools to really help fight the infection, improve chances for a quicker recovery, and hopefully improve survival. Our biggest hope, as Dr. Sellick was speaking about, remains for the development of a vaccine, which last count, there are likely dozens of groups working on various vaccine options. And the sooner we have an effective vaccine, the sooner we can think about relaxing our efforts to contain the disease through social distancing or return to what we knew as normal life. So that's what I have for updates in the ICU. Thank you for inviting me to speak. I'm happy to take any questions at the end of the presentation.
Thank you, Dr. There's a lot going on in the ICU, and this has been an incredible challenge for our team of doctors, nurses, and respiratory therapists in the ICU. With every illness and challenge, we look for evidence that life goes on, and nowhere is that more apparent than in the field of obstetrics, where babies continue to be born in spite of all the craziness going around them. Dr. Lisa Jane Jacobson is with our Department of Obstetrics at UBMD and works at Oshai Children's Hospital, and she's going to talk about COVID-19 and pregnancy. Dr. Jacobson.
Good evening, everyone.
You're muted right now.
I be heard at all?
Yes.
Talking about pregnancy. So there may be people out there who are pregnant. Questions that I would ask as a pregnant.
I think we've lost you again, Dr. Jacobson.
Oh no.
Now you're good. Now you're good.
You can hear me now.
You're in and out.
That's a problem. I don't know.
Now you.
Are you able to hear me?
Yes.
Okay, it is working. I'm still plugged in. I'm not sure what's going on, but all right.
We're good.
Let's keep going before I lose the microphone. So we can advance the slide. Okay, so here are the questions I would ask if it were me, right? Am I or my baby at risk during this time? And will COVID-19 be affecting anything about my prenatal care? How about my delivery? What will go on with the delivery? And what about when the baby's born? What do I need to be worried about as far as taking care of the baby and the baby's risk for infection? Next slide. So I do want to reiterate what my colleagues have been saying, that this is a very new disease for us here. We've only had it in the United States for about 3 months, so there is a lot of new information coming our way on a weekly basis. So a lot of what I say is what we know best at this point, but I'm sure we'll be learning more in the weeks and months to come. Next slide. So the good news that we have is that it doesn't appear that women who are pregnant have any more risk than the general population for catching COVID-19. So that's a very good thing for women who are worried, who are pregnant. And that's different from other viruses, because as we know, if you get influenza, the flu virus, when you're pregnant, you can actually get much more ill and develop a more severe illness than women who are not pregnant. But that doesn't appear to be the case with COVID-19. So that so far is very good news. And we do, of course, always warn all of our pregnant patients to protect themselves from infection of any sort. So it's important to always be careful, about bacterial and viral infections, and getting your vaccines in pregnancy for your other viruses, like the pertussis vaccine and the influenza flu vaccine. Those are very important, but unfortunately, we don't have one yet for COVID-19. Another question that moms might ask is if I get sick while I'm pregnant, am I going to give it to my fetus, my unborn child inside? It appears from what we know so far that it is very unlikely that if the mother has COVID-19, that they would transmit that to their fetus. So that's also positive news so far that we have. Now, once the baby is born, however, that newborn does have a risk of contracting the virus. So we have to take lots of precautions that we don't give it to the baby. We can go on to the next slide. So how does prenatal care differ in this COVID era here? Well, Dr. Morelli was sharing information about the way we've changed office visits, and we're doing the very same thing in our prenatal offices where we're doing our prenatal care. We are encouraging these telemedicine visits, so asking people if they can do teleconferencing, video conferencing like this, or even just using an iPhone or doing some FaceTiming. So whatever works for people, depending on what kind of technology they have at home. And then what that can do is avoid some of the contact that we would have otherwise, and maybe minimize the risk of spreading the virus. So some of the visits that you have can be done through the phone or on a web conferencing. Of course, as Dr. Marley said, we try to avoid crowds in the waiting room. So waiting in your car or outside may be best until the time of the visit. We do screen everybody at the door to make sure that they don't have any symptoms of cough or fever or trouble breathing. And we check for temperature. So, and all of the staff gets checked for the very same things every time we walk in the door. All of the healthcare providers are wearing their masks and sanitizing their hands all the time to prevent the spread. As we mentioned, there is no vaccine quite yet, but hopefully that will be in the future coming up. And we do recommend that pregnant women actually do get screened now for COVID-19. And the governor recently issued a recommendation that all pregnant women be offered a screen. And now we're really encouraging it for maybe 39 weeks or so, right before you're going to deliver, so that you'll know when it comes to delivery time, whether you're positive or not. And that might help us take care of you even better in the hospital. Next. So what could happen during the delivery? What's going on now? What kind of precautions are we taking? Well, I do want to remind you the hospital is still by far the safest place to deliver your baby. So you may be reading things online about people trying to deliver at home or in other situations. Of course, having a birth attendant or a person who knows what they're doing, is trained and licensed to deliver babies, is always essential, no matter what. But we're of the belief that the safest place is actually the hospital. And even with the virus around, it is still the safest place. So everyone who comes to the hospital will be asked to wear a mask. The delivery rooms are actually all single rooms. So you'll be in a room by yourself with your loved one. And the recovery rooms that you'll go to for postpartum after delivery are also single rooms. One of the things we get concerned about is that the heavy breathing and the panting and the labor during labor, that may increase the risk of the virus spreading with all that deep breathing and breathing out. So that we do want to make sure that the people in the labor room are protected. The support person that you bring with you will be offered testing as well, so that they actually could be tested to see if they're positive. I will give you a little forewarning that if you're going to be coming to the hospital, you have to carefully choose who you're bringing, because they're going to allow only one support person to be with you to minimize the crowd. And that person actually has to stay for the entire length of your process of laboring and delivering. And if they were to leave, they're not allowed to come back to, again, prevent the transmission or the exposure to more virus. So once they're there, they really do have to stay, and you can't substitute a different person in later on. So it's something to think about. Once you're in the hospital, if you didn't get tested before, we will encourage you to get tested for the virus. If you have a scheduled C-section planned, then we will definitely be asking you to be screened 3 days in advance, so that we'll know at the time of you coming in for the operation that whether you have it or not. And again, it will help the team better prepare and do all the safety precautions necessary to have to be careful about minimizing the spread of the infection. If you do happen to be positive, and we know that a person is positive for COVID-19 when they are in labor, we have special rooms designed to prevent the virus from spreading. And we also have special OR, operating room procedures, that are also, again, designed to keep people safe and prevent the virus from spreading. Next. So after the baby's born, we do need to be very careful about making sure that the baby doesn't get infected. Now, if you know you're negative, that can be quite reassuring. If you know that your caretakers or your loved one or your special, significant other or spouse is negative too, that can be very reassuring to the whole family. But if you are positive, then we are going to recommend that you stay, that you really have to be very careful. Everybody has their own choice here, but we are recommending 6 feet of spacing here between you and the the infant when possible. It might be helpful to have a caregiver that you know you can trust who is negative helping you with the care of the infant. You may have heard stories of places where their baby is being taken to a completely different room and having to stay there, and the mother is unable to see the child. But we're not doing that quite so much. It's always an option for a family, but we do recommend that you use all safety precautions possible. Keeping a mask on whenever you're around the infant, and of course using all the hand hygiene. And if you're going to have a person like a grandma or grandpa help in the care of the baby, including doing the feeding, you got to be very careful because, as we know, the elderly are more at risk of contracting the virus. And if there is somebody who has a lot of other illnesses as well, or hypertension and diabetes that have been just mentioned, you might be very careful about them being the primary caretakers too, if there's a virus in the house. All right, you got to be very careful about protecting those folks too. Breastfeeding is another question people ask. We definitely recommend breastfeeding, and we think that it provides protection against many illnesses, and it is the best source of nutrition for the newborn. But and we do believe, from what we know to date, that the virus is not likely to be spread through the breast milk. But we do want all mothers who are breastfeeding to wear a cloth face mask covering. The cloth face covering during their feeding and while they're washing their hands, and then to wash their hands before they breastfeed. So just again, being very safe and using all the precautions. And the same thing would hold if you were going to be pumping your breast. You'd want to before you handle the pump, you're going to be wearing the mask, you're going to be washing and sanitizing those hands and keeping the pump very clean. Now, although children are advised to wear masks, we do not advise children less than the age of 2 to wear a mask. So we do not want you to be putting any sort of a mask over your newborn's face. That would be dangerous. And there's a great danger for suffocation. So next slide. So for people who are pregnant or know someone who's pregnant and want to get some more information, this is a wonderful source here. And you probably can't write down this address here. So what you can do is Google these 3 words and you'll go right to the source you need. Google ACOG, American College of OBGYN, ACOG, ACOG, coronavirus, and pregnancy. You'll be right at that website. All right, take care.
Thank you very much, Dr. Jacobson. There's a few concluding observations I'd like to make, and then we'll have a few question and answers. So I'd like to ask our panelists to click in on their video and audio at this point. And I'd like to just give a few observations and some of the basics regarding limiting your risk. Next slide, please. I think many of us are back up one. I think many of us are familiar with these curves. We've been living with them for 6 to 8 weeks. The curve in the upper left is basically the normal course of a novel viral infection. And it's a fairly steep uptick. It's a fairly steep downslope, typically due to death and destruction. And we've seen that line across that peak, and it demonstrates what would happen if the number of patients who are ill overwhelmed the healthcare system. And what that means is that patients with COVID-19 illness would not get taken care of, accident and injury victims would not get taken care of, stroke patients wouldn't be able to get taken care of, patients who had appendicitis who can be treated in 12 hours, now the hospital would die for lack of treatment, care of pregnant women and newborn babies would be affected. So this is the worst possible scenario. To the right-hand side, you see the initial flattening the curve theory, and that is if we take measures to avoid that sharp uptick, that exponential growth of disease, we can flatten the curve and we can extend the course of the illness. But those of you who remember your high school geometry and trig classes realize that the total area under both of these curves is the same. The same number of people get sick. In theory, the same number of people die absent intervention of medical care, but it prevents the healthcare system from being overwhelmed and unable to take care of any patients with critical illness. The curve in the middle lower part, the pair of curves there suggest that with an aggressive lockdown strategy, what we've been able to do is not overwhelm the healthcare system and decrease the total number of people who would otherwise have gotten the disease. The problem, and this has come out in various presentations nationally, and I think we've heard the governor talk about it, is that although the uptick was quick, the downslope is not quick. It's much slower than the uptick in disease. And instead of a peak, it's a bit more of a plateau. And the question is, how long does it last? Do we get a second or a third wave? Do we develop in the interim therapeutics or a vaccine that change the course of this disease? Next slide, Megan. And actually, I'm going to have you jump because Dr. Sellick presented this, and you can jump this one as well. And here. So Northern Italy was the first region that we saw that we got what we thought was extremely accurate data out in a real-time fashion. And this is a paper that was from early April online. It was printed last week, but it demonstrates in the 72 hospitals in Northern Italy from February 20th to May 25th what exactly happened. And it was almost 1,600 patients, and they reported an ICU mortality rate of 26%. But of note, when they reported this paper, 920 of their 1,600 patients were still in the ICU. If you go to the bottom, it demonstrates that the patients for whom we know the outcome, those who either died or who were discharged from the hospital, 60% died, 40% survived. Now, we know now from more recent reports and what Dr. Nadler's told us that the mortality rate of ICU admission is probably in the 20 to 30% range, but it's still a disease with an incredibly high mortality, particularly in a broad patient population that includes those with pre-existing conditions and includes the elderly. And notice the age cutoff in this is 70, which gives you some idea as to who was and who was not admitted to the ICUs in Northern Italy. Next slide. Let's see. Go back one, I think. We may have skipped the Roosevelt. Do you have the Roosevelt? May have been deleted. Go down one slide. That's fine. So here we go. So the USS Theodore Roosevelt's a Nimitz-class carrier in the Pacific Ocean. And we're not going to go over any of the politics regarding their captain, but it's in a way a case study of this disease in a relatively young, healthy population. The disease of the crew of the USS Roosevelt numbers in the 4,800 range. The average enlisted man is in the 24 to 27-year-old range. The average officer is in their mid-30s. The oldest person on the ship is probably a naval surgeon in their early to mid-60s. The captain was 50. The admiral of the strike force was 53. They, over the course of 6 weeks, had 1,100 positive cases out of their crew of 4,800, to give you some idea as to how contagious this disease is. Of note, in this group, only 60% of the positive cases had any symptoms. There remain 3 people hospitalized, none in the ICU. There is 1 death among an individual who I believe was 41 years old. So the case fatality rate in this very closed population was less than 0.1%, which is actually less than the case fatality rate of the flu. Now, there were interventions that were taken. Healthy sailors were taken off the ship in the middle of this. Every sailor was tested multiple times. So it's an epidemiology study that gives us some idea of what it might be like in a high school or college population with a few certain warnings. Remember, these are generally young, healthy individuals. None of them went home at night to live with their 55-year-old parents and their 78-year-old grandparent. So this gives you an idea of what this disease is like in young, healthy individuals, and it may give us some clue as to what it would be like with high school and college students in the fall. There are lessons to be learned here, but there are warnings to be learned here. Next slide, please. So the high-risk features for spread have gotten some attention in the lay press. Population density is critically important. The population density and the multi-generational households in northern Italy are very similar to what you see in the boroughs of New York City. In the most populous boroughs in New York, the population density is 71,000 people per square mile. Multi-generational households are particularly common, particularly among the poor and the immigrant community in the New York City area. The picture in the lower left is from a New York Daily News article from a couple of weeks ago. It describes 3 generations of family living, 11 members living in a 2-bedroom house, a 2-bedroom apartment with the single bathroom, in which very quickly, I believe, almost everyone got sick. Use of public transit is an issue. You can see the picture on the right. Those of you who have been in New York can understand that. And these individuals often have essential worker status that requires them to go to work and require public transport. And so this is partly a poverty question. The comorbidities are listed on the right. I think that's been well addressed, that individuals with well-controlled hypertension and mild obesity still have very significant risk factors for morbidity and death from this disease. Next slide. So staying safe. At the present, there's some basic recommendations. Hand washing, viral distancing, and what that means is keeping your hands away from your nose, your mouth, and your eyes. Those of you who like to think like this contemplative writer on the right, your hands, you can have virus on your hands, you will not get infected, okay? But if that virus gets to the mucosal membranes of your nose or mouth, you will get infected. So no chewing on your pencil, no putting your glasses into your mouth as you're thinking and staring. It's really important. It's one of the Facebook cartoons that came out lately, the dog to the owner, it's for your own good, that cone around their head. So we've learned about social distancing. We've talked about masking. Selective isolation of our high-risk and elderly populations is probably going to be a way of life until we get a vaccine, or at least have very effective therapeutics going forward. There are 60 or 80 drugs in trial now. There are dozens of vaccine trials going on. Vaccine development is usually a relay where you come up with an idea, you design it, you then do a safety trial, you do a slightly expanded trial, then you do a very big trial. You follow the results for years, you get FDA approval, then you think about manufacturing up to scale. That's a relay that takes many years. Right now, all those steps are being done at the same time, so we can be hopeful that a vaccine could be developed, but we don't know that until it happens. My classic description of when a patient asks me how I know something, I tell them, I don't know I'm going to wake up tomorrow morning until I do. And that's the thought that scientists have to take in this. Next slide. And I believe that's the end. Thank you very much for attending this community webinar. We've had 1,000 people signed up. We've heard from our experts. We have a few questions that have been submitted. I'd like to address at least 2 or 3 of them. Not surprisingly, there are some about antibodies and testing. But before we get to that, there's one question about the risk factor of diabetes and whether it's majority type 1 or type 2. Type 2 diabetes outnumbers in the population type 1 by a factor of at least 10 to 1. It should be noted that type 1 diabetes is an autoimmune disorder, so it may have a specific risk factor with COVID-19 infection in the inflammatory phase. But when we talk about diabetes as a risk factor for COVID, we really are talking about type 2 or adult onset diabetes, which does have a particular type of fat, and it's been demonstrated that the receptor that the virus spike it associates with is actually present on fat cells. That's information that's come out this week. So that may explain in part why patients with type 2 diabetes have a higher mortality rate, and it's been documented they have a much longer course of illness. There are a couple questions regarding antibodies, and I'll defer this to Dr. Tomaszewski or Dr. Sellick. One of the questions is about the drop of blood test versus the blood draw in terms of which test is better to demonstrate a true antibody response in terms of screening. The New York State test was a drop of blood on a card test. The Kaleida test, which we've been running, which I have great confidence in, is a blood draw, in which it's a more extensive serology test, but I'll defer that to the experts.
Sure. Well, you can actually look this up. Laboratory medicine physicians usually talk about the sensitivity, the specificity, and the positive or negative predictive value of a test. So I'll just make a sort of blanket statement. If you're going to get a test, it should be what the FDA calls an emergency use authorization test, an EUA test. If you go to the FDA website, they will show you all these EUA serology tests, and you can see all the numbers for the sensitivity, specificity, and predictive value there and compare them. So you can actually look at the Wadsworth test, the New York State test, blood drop test. It's a good test, but it's really meant to be something that just looks at a population. We're looking for the epidemiology of where the virus has been, its prevalence in the population. It's a good use for that because you put it on a piece of paper, a drop of blood, you send it to the central laboratory, and it's actually kind of good technology that they use. But it's probably not going to perform quite as well as the blood draw test if that's a good test. We have a fair amount of confidence in the test that we're doing here at Kaleida. It's the Abbott SARS-CoV-2 IgG. It's the first one on that list, so you can look at the numbers for that. Kevin, we can't hear you. Kevin, we can't hear you.
Sorry. There was a question about the FDA approval of these tests. It's under an emergency use authorization by the FDA, which is not quite the formal final blessing, but it's much better than some of the mail-in tests that have come and are rapidly going.
Right. There are hundreds and maybe 200 of these tests out there, and they're all different. And most of them, if you don't have an EUA attached to it, you're probably somewhat at risk. You may remember in the news that there was a bunch of tests that hit Spain, I believe, and they pulled them all back because they had some horrible statistics attached to them. You're better off not having a test if it's performing like that.
Yeah. And there's a question regarding swab versus blood draw. The swab is for the presence of viral RNA or the actual viral antigen active infection. The antibody tests are post-infectious, so there's a tiny overlap between the presence of IgG with infection and the massive amount of IgG post-infection. But in general, we should think of an antibody test as a post-infectious test. There's a question about how we deal with individuals who don't have cars to get to their doctor's office, who don't necessarily have the technology to participate in telemedicine, or a Zoom session like this. Dan, do you have a comment about how the poverty is indeed a risk factor in terms of medical illness, the social determinants of health?
Well, that was something, Kevin, that we were aware of well before this epidemic fell upon us. We do know that there are zip codes where there are high prevalence of illnesses that with poor control and lots of risks for that patient population. And we can go right back to just a simple telephone. We've been using that for years for a lot of patient interactions when they've had questions about their care or their treatments. So the telephone, and most people can at least find a person with a telephone, and we can set up a time to talk to them.
There's a question about asymptomatic spreading, which I think we sort of addressed, and that's the hardest part for many in terms of dealing with this virus, that so many individuals can be spreading the virus without really having any symptoms or clue that they're sick. The people around them don't know that they're sick. And it's been suggested that aggressive testing and tracing can help minimize this. Do we have a comment, Dr. Sellick, maybe about whether that's true or not? Is your crystal ball clearer than mine on that one?
Well, I think that we always like to direct our testing to when we think there is something going on. But as you very aptly pointed out on the aircraft carrier, and this was also seen on the Princess cruise ship that had the big outbreak, that there was a fair amount of transmission of the virus without anybody knowing. And obviously, you've got a lot of people close together, and we're pretty concerned about this as we, even though we're still just in May and we're not even to graduation time yet, but we're concerned about when everybody goes back to school in the fall, depending on what that looks like, that we will see this kind of rapid spread through the population. And as you said before, even though the kids are probably not at great risk of bad things happening, when they bring it home or bring it to other people, then it's a problem.
Thank you, John. There's a question regarding the death rate in the U.S., which currently is at 72,000 among 1.2 million people who've tested positive. That number is certain to go up. 3 million people died in 2018. 72,000 deaths from COVID right now is the equivalent of a really bad flu year. However, we have parts of the country that are just beginning to deal with this. Again, I point out that in the situation of a novel virus, in which without intervention, 80% of Americans would get infected, we would expect a death rate between 2 and 3 million. There's a question about virus and antibody testing having high false negative results. Dr. Tomaszewski, you want to touch base? I think you mentioned this in part about the sensitivity of these two tests.
Yeah. So where do you get a false negative for PCR? The assay itself is quite good. It's very, very sensitive. But the false negative comes from when you test, where you test, and how you test. So we do know that you get infection in your upper nasal airways early. But if you get really sick, it actually can go down into your lungs and be cleared from your nasal airways. So you need to go for the money. You need to go to the spot where you think you actually have the highest infection, what we call tropism. So the infection goes to certain spots and not to others. So a kind of a rule of thumb is that you want your test to be when you are having symptoms, or if you're trying to screen populations, you want to get people who would have a nasal swab. You want to get a good swab, so you want to get back to that nasopharynx, and you want to handle the material quickly so that you get it to the lab and it doesn't degenerate. If you do all those things, you have a pretty good test. If you do only some of those things, you're going to lose, and you'll have false negatives.
Yeah. And in part, the question about antibody testing, I know, John, when you and I talked a week or so ago, when the Abbott antibody test became available, you took sera from a bunch of patients from a few years ago and ran it through, and happily not a single one of them came through positive. So right. It eliminated greatly the idea that, there may be cross-antigenicity with the cold virus or something like that, and that the patients who were known to have COVID-19, when they were tested a few weeks later, they were strongly positive. There were not indeterminate, oh, gee, it's at the borderline, that sort of thing. It was a very strongly positive test.
Yeah, and our data seems to continue to roll out in a positive way that way. So, all of these serologic tests are a little bit different. They see different things. At the end of the day, what we're going to want to know is what tests tell you about somebody who may actually have protection. And we're not there yet, but some of the features of those tests will be, you'll be able to calculate a titer. That means how much of the antibody is actually there. So more antibody, the better off you are. And eventually we'll start to know about the types, the specific subtypes of the antibodies, which we call epitopes. So you'll have antibodies to epitopes, and you'll know that these are things that are protective. But we're a long way away from that right now.
The next question has to do is why don't we know definitively if antibodies provide immunity? And are there tests to determine this? And what I'll answer this one in part because one of the interesting things about the vaccine trials has been some very novel ideas regarding how to accelerate the process in view of the threat that this virus has, both in terms of morbidity and mortality, as well as destruction of the economic structure of the civilized world, of the Western world, or of the whole world, I should say. So one of the things that's been proposed, for example, in these vaccine trials, is that you take a bunch of people, you test them for antibodies. If they don't have them, you then give them a vaccine. A month later, you test them, prove they have antibodies, and then you take healthy 18 to 24-year-olds and you deliberately infect them or attempt to infect them with the virus. It's called challenge testing. I'm not sure it would pass muster here, but there are several thousand people around the world who've actually signed up for that test to determine if antibodies, as we measure them, provide immunity. Now, the question is, what's the extent of the immunity? What is the duration? Does the virus mutate like flu virus changes, and the immunity we have this year is no longer good next year? So we don't know the answer to that yet, but there are some people who are thinking about that, and the ethics questions about this are very important. So there's a lot of good stuff in the lay literature about this, and I strongly recommend people read up on this because it's going to be very important, as we go forward over the next 6 months or so. There's a question about the different strains of COVID-19. There were press reports and I think a couple of medical reports in the last week that the strain that occurred in Europe is different from the strain that originally presented in Wuhan, China. I don't know if any of our panelists want to comment on that regarding whether there's increased or decreased virulence with this strain, but there's a slight change in the antigenic profile that was reported, I believe it was in Lancet this week.
Yeah, I think that this is not surprising. These little RNA viruses are always mutating. So you do whole genome sequencing, and there are people doing this around the world where they're just sequencing hundreds and hundreds and hundreds of strains of virus, and you can show particular mutations that show up. Many times they're useful for tracking, but the key thing to always remember is the mutations happen, but they become important if they result in a difference in virulence, how sick they make you, if it gets around our testing, or if it circumvents our vaccines. And obviously we have no vaccine. We don't have a good treatment yet, but I have not seen any information. The one big study that came out of Los Alamos lab is actually not out at peer review yet. It's on bioRxiv, and they made the big splash this past week. But even they seem to indicate that there is no difference in virulence in terms of how sick it made people, but maybe allowed it to spread a little bit more rapidly. It's hard to say, especially when you're looking, as you pointed out, the population density in New York City and the other big cities is so high, it becomes a little bit difficult to pin down how much is due to the virus and how much is due to just proximity of people to one another.
Yep. In order to accelerate the spread of knowledge, some of the rules of science in terms of publication and peer review have been somewhat suspended during this crisis. So typically when you have an idea, you have a theory, you test it, you write a paper, you submit it, and it bounces back between editors, reviewers, and authors over the course of months to a year or more before it's finally accepted after having been carefully, surgically ripped apart by very smart people who recognize the flaws and ask the right questions. Because that process takes time, papers now are submitted and are thrown up as pre-publicized, pre-print studies so that they become immediately available and researchers around the world can start to think about it, but they're not accepted. They're not what we consider to be peer-reviewed literature, and that's what Dr. Sellick was referring to. There's a question about masks and cloth masks. Do they really protect? I don't think we have an answer to that. The major advantage of a mask is it also helps you prevent from spreading with coughing and sneezing if you are that asymptomatic carrier. There's a question further about getting antibody testing. And it notes that they couldn't get it when they were sick, but now they're better. And when you're sick, it doesn't make sense to get antibody testing, but after you've recovered is when to get it. And there's and the question is they wanted to wait until it's more reliable. I think Dr. Tomaszewski addressed that antibody testing is quite reliable now. There's a question about whether we get herd immunity if we social distance. And the answer to that, John, is that we don't, but you live if you don't get the disease. Is that the comment about herd immunity? Do you think it's a valid, at this stage, it's too early? We may have lost Dr. Sellick.
Try again.
There's a question about can we get herd immunity if we social distance? And the two of those sort of go against each other.
Yeah, they do to some degree. But as you point out, we're balancing. Yes, we'd like to get herd immunity, but we'd like to do it with a minimal amount of carnage along the way. With this particular virus, based on its basic reproduction number, we would need somewhere in the vicinity around 60 or 65% of the population immune overall to stop this from progressing. Thing to remember is that the levels of herd immunity and the effective reproduction numbers vary from place to place. So areas that are not seeing a lot of virus, not seeing a lot of infection, are likely to do better with lower levels of background immunity. But certainly the places where there's very high population density, we're going to need higher levels of immunity. But again, as you said, it's we won't get herd immunity, but hopefully we'll be alive to talk about it.
Yep. There are several more questions about antibody testing in terms of how to get it and how to interpret it. And how to get it is that if your doctor writes a prescription, you can get it done at the Kaleida Health Laboratories. The turnaround is relatively quick, certainly within a day or two at the most. The question really comes how to interpret it. I don't know that I would suddenly decide that you could, go swimming or jump into a sauna with a bunch of hacking, whacking COVID-19 patients. We don't know for sure that it implies lasting immunity. I would put forward that if I knew that one of my children was antibody positive, I would probably have him or her do the shopping and grocery delivery for their grandmother. I'd invite a comment from Dr. Sellick, Dr. Tomaszewski,
So I
Morelli about that.
Yeah, so I actually I'm going to repeat what a colleague of mine said, and I think it's good advice. So if you're a glass half full type of person, and you get an antibody test, it's either positive or negative, right? So if it's negative, congratulations. All that social distancing and mask wearing and everything you're doing, it's working. Keep it up. If you're positive, well, maybe you got a little bit of an edge. I don't know. We'll know more in the future, but it's not a bad thing. So I also think that establishing a baseline in a population actually makes a difference. It helps us understand the progress of people as they interact with this virus. My fundamental thought is that what we want to know is not just about the viral particles and the antibody response, but we want to know that over time. We want to know the curves that people are on and where they're at and where they're going. And that tells us a lot. So I'm a big proponent of doing this testing.
Yeah. And again, questions that you do need a doctor's order to get the test done, but it is available at Kaleida Health lab sites. There's a question whether it can be spread through the walls of an apartment complex, and I think the answer to that is no. Could it be spread through a ventilation system? Questionably. ORs are positive pressure, which means we try to blow everything away from our patient. But if you're operating on somebody with tuberculosis, you generally don't do that in the hospital. You have what's called a negative pressure room. There's a question about viral load causing symptoms. I defer this to the experts as well. I know that the highest viral load in terms of, or the highest exposure to viral load is among surgeons who work in the nasal and respiratory tract, those doing tracheostomies, and ear, nose, and throat surgeons doing surgery on patients they don't realize are COVID positive, doing sinus surgery. Some had died. And the theory there is that that's a high viral load. I don't know that that's true, but does anyone else have a comment on that?
Well, I'll just make one comment. That is that people that are sick, symptomatic, tend to have viral loads. We call this LOD, level of detection, in the 10,000 to 100,000 to million range. Our assays at Kaleida we can detect a level of about 100 copies of virus. So, so if you're symptomatic, you usually shed a lot. But if you're not symptomatic, you probably can be all over the board. Dr. Sellick?
I think we're pretty much at the end of our many questions. We'd like to thank the hundreds and hundreds of people who joined us this evening. I'd like to thank each of our panelists for their contribution tonight. I'd like to recommend everyone stay safe, keep themselves informed, and please realize that life is going to go on for the next several months to a couple of years as we deal with this. We have patients who need medical care. We can provide that medical care. We've been working hard to make our hospitals and offices safe for patients. We don't want people to die or be disabled from readily treatable disease out of fear. So I thank you very much for attending, and I thank all those who contributed tonight to this seminar. And again, good night and stay safe.